Hello everyone, my name is Michaela and joining me today we have Abby, Gabby, Lara and Leon. Soon we will be discussing ectopic pregnancy and giving you an in-depth and informative refresher on its sometimes drastic implications on your patients. Did you know that in Australia, 2 in every 100 pregnancies are defined as ectopic? And although it is rare to die from this condition, our advanced medical treatment and early detection via routine pregnancy ultrasounds helps to prevent this. But how and where does an ectopic pregnancy manifest?
As the ovum is expelled from the dominant follicle, the fallopian tube will carry the fertilized ovum into the uterus for implantation onto the endometrial lining. However, certain conditions may impede this process, and they can be classified into these two broad categories: conditions that interfere with the transport of the fertilized ovum, and conditions that cause premature implantation of the fertilized ovum. Consequently, it is implanted at the fallopian tube or at another abnormal location. It should be noted that approximately 50% of patients with ectopic pregnancies are idiopathic. However, there are three main risk factors that have a significant association with ectopic pregnancy. These include previous history of trauma, such as prior tubal surgery or ectopic pregnancies, the use of intrauterine devices, and pelvic inflammatory disease. Other risk factors include tubal abnormalities, having more than one sexual partner, increased maternal age, the use of assisted reproductive techniques, endometriosis, and sexually transmitted diseases. As a result, it is essential that we as sonographers gather a thorough medical history prior to scanning.
The clinical manifestations of ectopic pregnancy vary between tubal and non-tubal ectopic pregnancies, although the common presenting symptoms include abdominal or pelvic pain and vaginal bleeding. Ectopic pregnancies can usually be detected between 6 to 10 weeks gestation. Early detection is essential for effective management. Symptoms will begin with amenorrhea, followed by abdominal pain, vaginal bleeding, shoulder tip pain, cervical excitation, and sometimes with a probable mass present. Studies have found that the presenting symptoms vary between tubal compared to non-tubal ectopic pregnancies. Non-tubal ectopic pregnancies often present with syncopal episodes and occasionally diarrhea. Tubal ectopic pregnancies often present with significantly higher abdominal pain and vaginal bleeding than non-tubal, and will often present with shoulder tip pain. Vaginal bleeding occurs due to the low levels of progesterone, and abdominal pain occurs due to the parietal peritoneum becoming irritated. Ectopic pregnancies may also present without any vaginal bleeding, where implantation occurs in the ovary. Ectopic pregnancies share very similar clinical presentations to tubal choriocarcinomas and heterotopic pregnancies, allowing error for misdiagnosis in the clinical environment. Heterotopic pregnancy is rare and is the coexistence of both intrauterine and extrauterine pregnancy.
A specific sonographic criterion exists for the diagnosis of tubal and non-tubal pregnancies. In a tubal ectopic pregnancy, 95% approximately, an ectopic mass can be visualized in the adnexa separate to the ovary and within the fallopian tube. The adnexal mass may appear as inhomogeneous and ketogenic, a gestational sac enclosed by the hypoechoic ring, commonly known as the vagal sign, or a gestational sac with a fetal pole with absence or presence of cardiac activity. Another useful marker of tubal ectopic pregnancy is the corpus luteum, visualized as a ring of fire using color Doppler on the ipsilateral side. Free fluid within the uterus or pouch of Douglas can also be suggestive of ectopic pregnancy in the absence of IUP. Hemorrhage is suggested from a ground glass appearance. Diagnosis cannot be made solely on this, as a small amount of free fluid is considered physiological. 5% of ectopic pregnancies are non-tubal, with their locations including interstitial pregnancies, cervical pregnancy, cesarean section scar ectopic pregnancy, and ovarian ectopic pregnancy. Interstitial pregnancy ultrasound diagnosis relies on the absence of IUP with the presence of trophoblastic tissue outside the endometrial cavity. These pregnancies have a thin continuous rim of myometrium with tendency of rupture between 8 to 16 weeks. Cervical pregnancies are rare, with diagnosis based on an empty endometrial cavity and the gestational sac implanted below the level of the internal cervical os. There is also an absence of the sliding sign, where pressure is applied to the cervix and the gestational sac slides against the endocervical canal. Ovarian ectopic pregnancy is difficult to differentiate from other ovarian pathology. It presents as a typical cyst appearance with a wide echogenic outer ring. CSEP ultrasound diagnosis is determined by the absence of the sliding sign, an empty endometrial cavity, and the gestational sac located at the level of the previous cesarean scar.
When a patient presents with symptoms suggestive of an ectopic pregnancy, transabdominal, transvaginal ultrasound imaging, and beta-HCG levels are used in conjunction for diagnosis. Transabdominal ultrasound is recommended primarily as it obtains a superior overview of the pelvis. Unlike transvaginal ultrasound imaging, transabdominal ultrasound imaging can visualize intraperitoneal fluid, intra-abdominal hemorrhage, and other differential abnormalities. Consequently, transvaginal ultrasound is performed secondary due to its increased sensitivity and proximity to the anatomy, allowing clearer visualization of the uterus. Beta human glucan gonadotropin, beta HCG, is a hormone produced in the placenta and levels are the highest throughout the first trimester. Consequently, ectopic pregnancies with a suboptimal increase, less than 50%, in 48 hours or a plateau of beta HCG values suggests an ectopic pregnancy. Therefore, this combination of diagnostic techniques aid one another in sufficiently identifying an ectopic pregnancy, ensuring early detection, thus allowing effective treatment to commence. There are numerous ways to treat an ectopic pregnancy. Ultimately, management is dictated by presenting factors, including symptoms, ultrasound findings, and clinical presentation. Expected management involves a patient being monitored while the pregnancy is passed naturally. Criteria to be met includes minimal symptoms, hemodynamically stable, and HCG levels declining. The patient may experience vaginal bleeding, abdominal pain, and require follow-up to investigate HCG levels are declining due to the passing of the gestational sac. Methotrexate is a medication used to inhibit the growth of dividing cells. Symptoms will be like miscarriage. Criteria to be met includes ectopic mass less than 5 centimeters, no embryonic cardiac activity, and hemodynamically stable. This must be followed up by a blood test to determine if the treatment is effective. Salpinectomy involves a small incision made in the fallopian tube wall and the gestational product is removed. This is the preferred treatment when tubal pregnancy is unruptured and is a less invasive procedure with a faster patient recovery and preserves patient fertility. Salpinectomy is the removal of the fallopian tube which the gestational sac is located. This option is necessary in circumstances with a large ectopic, previous history of ectopic pregnancy, and tubal rupture. Advantages in surgical and medical therapy for ectopic pregnancy allow for the proliferation of minimally invasive treatment, resulting in superior patient comfort and experience at an often very difficult time.
To conclude our presentation today, we hope you, as an audience, take home a firm and further informed understanding of ectopic pregnancy and can implement this knowledge into your everyday life as a newly graduated sonographer. Keep in mind this can be an incredibly sensitive and important topic where patients who present with this condition need to be correctly informed and often comforted. We, as a group, hope this has been an engaging and enlightening presentation. Thank you for your attendance.